اسمي دكتور شريف نجم، endocrinology and internal medicine consultant. النهارده هكلمكم على common questions in MRCP exam سواء ال first or the second part. You are a doctor in emergency room. You see a patient presented with decreased level of consciousness, rigidity, hyperpyrexia, marked raised CBK. هنتكلم على العيان ده if he is taking antipsychotic and recently increased the dose, or taking anti-Parkinson treatment and suddenly stopped the treatment due to any cause like negligence, dementia, he forgot to take the medicine, or gastrointestinal illnesses. This points to the neuroleptic malignant syndrome. Okay. النيورولابتيك malignant syndrome في سببين مهمين جدا. أول سبب فيهم increase the dose of antipsychotic. تاني سبب ليهم وده اللي بيبقى مازد من دكاترة كتير حتى دكاترة المخ والأعصاب اللي هو العيان suddenly stopped the anti-Parkinson treatment. It takes around 10 days for the patient to develop the manifestation. Presented with hyperpyrexia, severe rigidity, and this severe rigidity, it will lead to muscle breakdown. So there is a raised CBK and all the muscle enzymes like the myoglobin, and also there is hyperpyrexia. The management here is stop the antipsychotic immediately, start intravenous fluid to protect the kidney because this will lead to rhabdomyolysis. So there is deposition in the tubules of the kidneys by the myoglobin, and this will lead to acute tubular necrosis. Start dantrolene as a muscle relaxant. This may be useful in selected cases. Okay, adding bromocriptine, dopamine, to enrich the dopamine supplement in this patient, especially in patient on anti-Parkinson treatment. The أول differential diagnosis, the neuroleptic malignant syndrome. So the same presentation, male patient, okay, old age, comes to you in the emergency, okay, with severe rigidity, hyperpyrexia, may be found comatose at home, and raised CBK. The next differential diagnosis with the same presentation if the patient is taking selective serotonin reuptake inhibitor or tricyclic antidepressant, and he visited the psychiatric and he added a new drug as an antidepressant. In this condition, you should think about serotonin syndrome. It can also occur when adding linezolid to the antidepressant, ST John warts, and also patient taking cannabis to antidepressant. This all may lead to serotonin syndrome. The clinical presentation, it looks like the malignant hyperthermia and also the neuroleptic malignant syndrome, except it will occur in hours, unlike the neuroleptic malignant syndrome that it takes 10 days to occur. The next thing, that serotonin syndrome will result in hyperreflexia, myoclonus, especially in the lower limb, and also this is a differentiating point between it and the neuroleptic malignant syndrome, the presence of autonomic manifestation like the variable blood pressure and the inappropriate sinus tachycardia also points to the serotonin syndrome. The next presentation in differential diagnosis, okay, the management, immediately stop any serotonergic agent, okay, using benzodiazepines for agitation because this will increase the CBK and the muscle enzyme, and also it will lead to rhabdomyolysis and acute tubular necrosis. And consideration of the use of serotonin antagonists like cyproheptadine if there is severe autonomic manifestation associated with serotonin syndrome. The next, in differential diagnosis with the same presentation, which is the patient coming to you to the emergency with hyperpyrexia, severe agitation, may be found comatose with raised CBK, but in this situation we're talking about a young age patient, okay, collapsed, found at the nightclub with his friends, comes with his friends, okay. هنا في الحالة دي بنتكلم على the ecstasy poisoning. Okay, in this condition, the intoxication will lead to serotonin syndrome. Okay, it looks like the serotonin syndrome, especially if the patient is taking any drugs associated with the serotonin syndrome. As we talked about the serotonin syndrome, the linezolid, the tricyclic antidepressant, the selective serotonin reuptake inhibitor, and the ST-Johnwars. If associated with ecstasy, it can lead to serotonin syndrome. The management of ecstasy overdose, supportive treatment, just fluid to ensure that there will not be tubular necrosis, and dantrolene to relieve the agitation. It may help. Okay, the next in the differential diagnosis is a condition related to general anesthesia. So the patient after general anesthesia is presented to you with hyperpyrexia, presented to you with severe agitation and also muscle breakdown that will lead to raised CBK. This is malignant hyperthermia. Okay, this is an autosomal dominant condition. It's due to that the succinylcholine in this susceptible genetic mutation, which is autosomal dominant, it will lead to severe muscle contraction and rigidity as a result of impaired calcium homeostasis in the skeletal muscle. Also, it will lead to hypercapnia, tachycardia, muscle rigidity, and rhabdomyolysis. So also the management will be here with vigorous fluid intake, also relieve the agitation and the severe muscle contraction with dantrolene. It may help. Best wishes for you.